Good morning, everybody. Welcome to Phoenix Children's Grand Rounds. Wherever you're joining us this morning, it's wonderful to have you with us, and we're glad that you've decided to spend some time this morning with us. Our speaker this morning is Dr. Rajeev Bhatia. You may have noted, if you've been to the last couple Grand Rounds, we've had invited speakers, actually candidates for the University of Arizona Medical School department chair position. And our third such applicant will be actually at next week's Grand Rounds, but we're very excited this morning that we have a PCH-based speaker, one of our own, Dr. Bhatia. Dr. Bhatia is the Division Chief of Pulmonology at Phoenix Children's, having come to us from Akron, Ohio in 2019. In addition to being the Division Chief, Dr. Bhatia also serves as the Co-Director of the Human Performance Lab here at Phoenix Children's. Dr. Bhatia completed medical school at the University of Delhi in India, and then came stateside and completed his pediatric residency at Maimonides Medical Center in Brooklyn, New York. He then completed a fellowship in pediatric pulmonology at Children's Hospital of Los Angeles. Dr. Bhatia has many peer-reviewed publications in the area of cardiopulmonary exercise testing, and his talk this morning will be in the area of exercise-induced dyspnea in children. Is it always asthma? Please welcome Dr. Bhatia.
Thank you. Okay, thank you for giving me an opportunity to present today. I don't have any disclosures in relation to this talk. So the objective of this talk is at the end of this meeting, we should be able to identify and manage exercise-induced bronchoconstriction, exercise-induced asthma, recognize other causes of exercise-induced dyspnea, and understand the utility of cardiopulmonary exercise testing. So I like to keep things simple. So it is what, so what, and now what. So what it is, why it is important. So what, if we recognize other causes, why that is important. And in the end, if we know that it is likely something else, then what can we do about it? As you know, there is obesity epidemic in the US, and as more and more patients are exercising, we are getting more patients as pediatricians and pulmonologists with exercise intolerance. And it's our duty to identify these patients, the cause of exercise intolerance, as well as we can find the cause and give them exercise prescription. I like to learn anything new with the help of a case. So what I've decided to do is we will go through this case, and while we are going through this case, we'll learn about different causes of exercise-induced dyspnea and cardiopulmonary exercise testing. This is a real case. A few years back, this is a 16-year-old female, a competitive soccer player, who presented with chief complaint of exercise-induced dyspnea. Her symptoms would start within 10 minutes after the start of the game. She complained of mid-sternal chest tightness. There was no cough or wheezing. She wasn't sure whether her symptoms were during inhalation or exhalation. I always ask that, and you will find out why. And her symptoms would resolve within 5 minutes when she would stop exercising. In other relevant history, she had mild eczema. There was no history of any allergic rhinitis, hypertension, or congenital heart disease. There was no other significant past medical history. She was a highly competitive soccer player. There was no family history of asthma, atopy, sudden death before 50 in the family, or any unusual heart issues. She lived in a house which was carpeted, and there was no pets, and there was no history of smoking, either in the patient or in the family. So at this point, once she started to have symptoms, she saw her pediatrician. She was put on inhaled albuterol before exercise. That did not help. Then appropriately, she was put on once daily Montelukast. That did not help. And then in the end, out of frustration, pediatrician put her on a combination inhaler, which, when that did not work, she was eventually referred to us for further management. On her physical exam, It was normal, except she had a benign murmur. Baseline spirometry was normal, and at this time, parents were anxiously looking at me for answers. So at this time, I did not know what's going on. So we will learn about different causes together, and then we'll come back to the case. So as we know, the exercise-induced bronchoconstriction, it involves the airway narrowing either during or actually following exercise. Patients with asthma, no one exactly knows what is the prevalence of EIB in patients with asthma, but more than 90% will have EIB. Important thing to remember is that in elite athletes, it can occur without underlying asthma. The hypothesis is that the elite athletes are exposed to allergens. Let's say a swimmer who has been swimming many hours in a week has been exposed to that chlorine in the water, and that can induce asthma. Common symptoms include dyspnea, chest tightness, cough, or wheezing. Important thing to remember, the greatest bronchoconstriction happens 10 to 15 minutes after the exercise is stopped. And if the patient is not given any kind of inhalers, then it takes up to 30 to 90 minutes to get better. Interestingly, the pathogenesis of exercise-induced bronchoconstriction is still not well known. The hypothesis is that when patients start exercising, the system is not able to humidify and warm the air soon enough, and that cold and dry air leads to inflammatory mediators, and that is activated via sensory nerves. Epithelium also plays a role by sensing the transfer of that heat and water. But how exactly epithelium leads to release of these inflammatory mediators is not clear. So we have decided, we have looked, we evaluated the patient, we think the patient is EIB, but how do we confirm it? As many of you might have heard about it, it's exercise challenge testing. And I will refer to exercise challenge testing as a simple exercise challenge testing just to differentiate from cardiopulmonary exercise testing. So what we do here is we do a breathing test, that is spirometry, before making patient run on a treadmill. Then we make patient run on a treadmill at 80 to 90% of the predicted heart rate. And what is a predicted heart rate? That is 220 minus age. Let's say a patient who is 15 years old, 220 minus age would be 205, and 80 to 90% somewhere is 160, 170. So the patient should be running at 160, 170 of heart rate for 6 to 8 minutes. And after that, we repeat the spirometry at 5, 10, 15, and some places do 0, 3, 6, 9. That's what we do here, to look for if the patient had any drop in the airflows. If you look on the right, the upper loop, the loop on the top is expiratory loop. The loop below is inspiratory loop. The black is the one before, and the red is after. So as you can see, post-exercise, there is more scooping, suggesting the patient had bronchospasm. In my previous place, when I joined there, I saw that there were a lot of exercise studies being sent by outside pediatricians. These are the patients which we had not seen, but just sent for exercise challenge testing. And there wasn't anything wrong about it, but we just wanted to find out what is the efficiency, how many times we are able to help these pediatricians when they have ordered this test. So we looked for 5 years, from March of 2011 to March of 2016. We had 164 tests, and what we found out that only 19% were positive for EIB. So one important thing to remember, if you have a patient with exercise-induced dyspnea, and we order an exercise challenge testing, and that if that comes negative, then you are back to square one. You do not know why the patient is having exercise intolerance. Other important thing, what we found in this study is that there was no association between the test being positive or negative and what the gender of the patient, whether the patient had a diagnosis of EIA. EIA is exercise-induced asthma. Remember, I'm not saying asthma, I'm saying diagnosis of EIA. Because many times we give the diagnosis of EIA loosely, so we did not find any association between diagnosis of EIA and the EIB status. Also, If the patients had a very typical symptom, that also did not make a difference. That also did not make it more likely that the patient would be positive. And if patient had used albuterol or not. Other important thing, what we found that patients who did not have diagnosis of asthma are almost 3 times more likely to have a negative test. That means 7 out of 8 subjects without a clinical diagnosis of asthma showed no evidence of EIB. So these many patients, so almost 80% patients, we were not helpful. We said the test was negative, but we did not give them an answer. So we finally concluded that in these patients, especially who do not have diagnosis of asthma and having exercise-induced symptoms, it is better to order cardiopulmonary exercise testing instead of exercise challenge testing. So let's say we have diagnosed a patient with EIB. So what do? This is from the article, from a New England Journal article from 2015, and it mainly talks about athletes, but is applicable to any patient. Just going to quickly run to the coffee. Sorry, I'm just getting a dry mouth. So there are 2 components to EIB. One is prevention. So as we know, if a patient has asthma, you want to make sure there's an effective asthma control. Pre-exercise warm-up is what 10 to 15 minutes of pre-exercise warm-up can lead to up to 2 hours of refractory period. So we always tell our patients to warm up. We all know about using the inhaled bronchodilator 15 to 20 minutes before activity. If a patient has bronchospasm, obviously you can give a rescue therapy. And if just the rescue therapy is not able to control it, then adding a maintenance therapy is reasonable. My rule of thumb is if patient is needing albuterol daily, then I tend to add something, either inhaled steroids or combination inhaler or montelukast. So let's come back to our case. So we have learned that EIB presents 10 to 15 minutes into the game. This patient also had within 10 minutes of the exercise. So that kind of goes in favor. However, the thing which doesn't go in favor is that her symptoms would improve within 5 minutes. But remember, we said that it takes up to 30 to 90 minutes to get better. So she had some symptoms which were suggested, but it was not classical. She did not have other risk factors for asthma except she had mild eczema. And more importantly, she did not respond to asthma meds. So one thing I want to highlight here is that albuterol has a placebo effect. If a patient, many times patient would say that albuterol is helping. The question I ask them is that, let's say you forgot to take one day, did that make any difference? And if they say that they don't miss, if they have forgotten, but still they would not miss it, that kind of tells me it is not helping them significantly. So before we move to other causes, so I'm thinking about this patient and I said, okay, it doesn't fit into EIB. So then I started thinking of what are the other causes. Other relatively common cause is vocal cord dysfunction, and many of you might have heard it. So what it is basically is when you are running, when you are taking breath in, our vocal cords open to let the air in. But in some patients, instead of opening, it closes, giving them a feel that they can't breathe. Any patients, even patient has asthma or not asthma, if you are having a difficulty controlling their symptoms, even with adequate treatment, always consider vocal cord dysfunction. Remember, vocal cord dysfunction can coexist with asthma. Most of the vocal cord VCD patients are female. Exercise is a common trigger. Actually, reflux in some studies show that that could be a trigger as well. As I said previously, asthma can coexist, and that can make things a little difficult. Patients are often on multiple asthma medication by the time they come to us because the pediatrician or whoever is treating is just the albuterol is not helping, then they add single air or montelukast, or they add inhaled combination inhalers, and they keep piling that up. But the problem is somewhere else. And why it is difficult? Because the symptoms of VCD are very similar to asthma. The differentiating features are stridor, and as well as sometimes patients tell me that they feel like as if it is choking, and they complain of some throat tightness. This picture will make it more clear. So on the left, we have vocal cord. This is the larynx, and these are vocal cords which are completely open. This is a symptomatic VCD patient and this is the anterior part, and during symptoms, this anterior part closes, leaving a posterior opening, which is called posterior chink. On the right is spirometry, and on the left side, this is the expiratory loop, this is the inspiratory loop. The expiratory loop in patients with VCD is usually normal. It is the blunting of the inspiratory loop which is suggestive of vocal cord dysfunction. Why there is blunting of inspiratory loop? Because it is a problem during inspiration. It is an extrathoracic obstruction in contrast to asthma, which is intrathoracic. So just to further stress my point, how to differentiate between vocal cord dysfunction and asthma or EIB is one is extrathoracic, another is intrathoracic. I would say both are relatively common. Obviously, EIB is more common. Other important thing to how you differentiate is vocal cord dysfunction is usually dramatic. Patients, it starts abruptly, stop abruptly. And many times you would see 911 is called, paramedics at the scene. This you usually don't see in patients with asthma because the symptoms are gradual. Both can have frequent ER or office visit, but one differentiating feature where I always ask my patients is when you went to the ER, what were your SATs? If their SATs were normal, it can be normal in asthma too, but patients with such a dramatic episode and having a normal SATs kind of point me towards VCD. As we talked about the spirometry, in VCD you have a blunted inspiratory loop, whereas in EIB you have the expiratory loop, which is scooped. The treatments are completely different. For EIB, these are inhalers. For VCD, it is breathing techniques. We send them to speech therapy. And what they teach them is to take away their attention from their upper airway to diaphragm. So they teach them diaphragmatic breathing, and that is actually very helpful. So coming back to our case, she did have some history of anxiety. So the relationship between anxiety and VCD is kind of interesting. Actually, for a long time, we believed that patients who are anxious, they're more likely to have VCD. But actually, that turned out to be not true. It's not anxiety, actually. It's the type A personality. People who are really ambitious tend to have more VCD. And sometimes I tell my patients, and these patients are actually very smart, so I tell them sometimes that this is being a side effect of being smart, and that really amuses them, and kind of bring them on board to accept therapy. For this patient, relatively quick improvement goes in favor. Remember, she improved within 5 minutes, but she was not able to recall whether this happened during inspiration or expiration, and there was no history of any obvious stridor or choking. So now I have explored two common causes. One is EIB, another is VCD, and I'm still not 100% sure what this patient has. So at this point, I'm thinking my next step would be to do a cardiopulmonary exercise testing and explore what is the reason of her exercise intolerance. So let's quickly learn about cardiopulmonary exercise testing, and then we'll come back to this patient again. I know you're seeing a big definition there. So what, in summary, what it is, basically we are testing heart, lung, muscles under stress, and their cooperation, their coordination under stress. The important thing is non-invasive. It's important to differentiate this from exercise challenge testing. Remember, the exercise challenge testing is just doing a spirometry before, making patient run, and then spirometry afterwards. Whereas the cardiopulmonary exercise testing, when they are running, we are measuring many parameters to see what is limiting their exercise. This is actually a famous interlocking gear model by Wasserman. And what actually it tells is that as patient starts to exercise, these interlocking gears start to run fast and faster. And what basically it is as there is an increased demand of oxygen at muscle level, there is increased extraction, there is dilatation of peripheral circulation, there is increased cardiac output, dilatation of pulmonary circulation, and increased ventilation to provide, so it's kind of matching that oxygen utilization by running this faster and faster. So how do we do it? Basically, you see on the right is my patient from my previous institute. It's actually a CF patient. And you see a mouthpiece, which is connected through many channels to the computer, which is measuring all these parameters. So what are these parameters? On the left, you see the metabolic rate, basically oxygen consumption, CO2 production, cardiac function via heart rate. We measure heart rate and EKG, and we also have a pulse ox to measure their sats. So see, we are looking at metabolic rate, cardiac function, and respiratory function. This is actually a protocol from my previous institute, but most of the places use a similar protocol, and we use pretty similar protocol here too. So what it is, basically, there is a warm-up, and there's an exercise period where we are gradually increasing either the speed or the grade of the treadmill. Our goal is to increase the workload incrementally so that we can push patient to their max, and then there is a recovery period. So here I just want to quickly show a video just for you to get a sense of how does it look. So this is one of our patients who is running on a treadmill. You see, this is two screens. We are looking at different parameters. You can see a mouthpiece. Here we use face mask, and actually that is preferable because patient can speak. And this is the EKG, and this is on the left. We are measuring breath by breath these multiple parameters. On the top, you see the sats and the heart rate. Okay, so hopefully you got the idea how exactly it is done. Next couple of slides, I'm just going to go over a little physiology, and I promise I'm not going to go too deep. I'm just going to highlight a couple of parameters which you might have heard of, and what do they mean. On the right, you see is on the x-axis, you see how as we are increasing the work rate, that's what is on the x-axis. On the y-axis are the different parameters. There is a normal physiological response of all these parameters. There are one or two parameters which we are truly interested about. One is the VO2 max, which many of you might have heard about. What that is basically how much oxygen patient was consuming at the peak exercise, and that is a marker of fitness. Another important parameter you might have heard of is called anaerobic threshold. And what that is, as we start to exercise, initially the oxygen delivery is able to keep up with oxygen utilization. But as we are exercising, there is a point comes when the oxygen delivery is not able to keep up with oxygen utilization. And at that point, the anaerobic metabolism need to supplement the aerobic metabolism. So this anaerobic threshold is the point, is the VO2 at which that anaerobic metabolism kicks in. So why that is important? It is important, especially in pediatric population, because it's a submaximal parameter for fitness. So even if patient does not give us a full effort, if they reach that anaerobic threshold, we can kind of guess if they are fit or not. It usually happens, the anaerobic threshold happens almost at middle of the exercise. Closer it happens towards the VO2 max, fitter the patient is, and sooner it happens, less fit the patient is. So that's how it can give us an idea about the fitness, even if patient does not exercise to the maximum. Other important principle to remember is that as patients start to exercise, the cardiac output increases. The initial 40% it mainly increases by stroke volume. After that, it mainly increases via increase in heart rate. And the heart rate increases linearly with the workload, such that at the peak exercise, the peak heart rate is achieved. That's why we use peak heart rate as a surrogate marker for the best effort, or the patient, whether the patient has given the best effort or not. Other important concept is breathing reserve. When patient starts to exercise, even at the peak exercise, there is 20 to 40% more capacity in her lungs, in patient's lung, to go further. So it's not lungs usually which make patients stop. And my mentor used to say, and that's how I remember, which might offend my cardiology colleagues, that it's a wimpy heart which makes you stop, not the majestic lungs. However, if you have pulmonary disease, then your breathing reserve is going to be low, and that's a sign suggesting that there is some pulmonary issue. When I read an exercise study, a couple of questions I ask myself. First of all, did patient exercise at or near their physiological maximum? Because we really want patient to give their best effort, otherwise we would not know if their numbers were low because of the effort or there is something wrong. Next is whether the patient is fit, whether they have a normal aerobic capacity and fitness. What limited exercise in that particular patient? So as I was saying, normally it's a heart and muscles which makes you stop. It's rarely lungs. So, or abnormally, heart can stop you abnormally too. So we want to see what is limiting their exercise. And lastly, is there any evidence of exercise-induced bronchospasm or any other abnormal response to exercise? Coming back to our gear model, I'm not going to go in detail, but I just want to, with this slide, I just want to highlight, when we look at this study, there are particular responses happens with limitation by particular organ system. If it is by muscle, you have a different response. If it is by heart, it's a different response, and if it's by lungs, you have a different response. And sometimes it is multifactorial, so sometimes it needs a little more experience to look into and tease which is the primary cause and which is secondary. But I just want to highlight that there is a different responses and when there's a limitation by different system, which help us decide what is the main cause of exercise intolerance. So coming back to our patient, so we ordered exercise testing, cardiopulmonary exercise testing on this patient. She did give us a good effort. She had a normal aerobic capacity and fitness. Exercise was limited by normal cardiovascular mechanism. She did not show any EIB or vocal cord dysfunction, and EKG was fine. So here we were stumped. I had promised parents that we will have an answer, and this all was fine, which is not bad. We can tell patient there is not something wrong with the patient or significantly abnormal, but that did not satisfy the parents. So as I was going through the study, or when we looked through different responses, one thing which we found was striking. What was that is that her ventilation in comparison to her oxygen uptake was significantly higher. What that means was she was voluntarily hyperventilating. And when I looked at her CO2, that her CO2s were in 30s, which suggested that she was primarily voluntarily hyperventilating, and she did have some lightheadedness and tingling in hands towards the end of the exercise. When I explored it a little further, she did mention that she had similar episodes in the past. Paramedics were called, but symptoms resolved without treatment on both occasions. So that made me think what she had was exercise-induced hyperventilation. So what is exercise-induced hyperventilation? What exactly it is that when your ventilation exceeds the metabolic demands. It can happen in acute anxiety, but I have seen patients without anxiety with exercise-induced hyperventilation. Unfortunately, we do not have any set criteria to diagnose, but important thing to remember, if someone is having a much excessive ventilation and their CO2s are significantly lower, that suggests primary voluntary hyperventilation. And the treatment is breathing techniques or anxiolytic pharmacotherapy if anxiety is the primary reason. I actually had another interesting case maybe 2 years back. This was a stage runner, and she would pass out. Her times started to deteriorate, and she started passing out during activity. She had a full cardiac workup. Actually, she went to Cleveland Clinic and had a complete autonomic function studies, and it was really frustrating for the parents. So then eventually someone heard about her exercise lab, and she was sent to us. And we found that she had exercise-induced hyperventilation. And what was happening, her CO2s were going significantly down, and that made her having a lightheadedness and passing out. What we did for her is we just sent her for breathing techniques, sent to a psychologist, and she was significantly better. So in last couple of few slides, I'm going to go over a couple of other causes of exercise-induced dyspnea, and in the end, I'll give the algorithm I use when I'm evaluating a patient with exercise-induced dyspnea. So what is physiological limitation? We do see some kids with physiological limitation. What that is, that when we are exercising, our ventilation increases by 6 to 7 folds. And in some patients, they have this excessive psychophysiological sensation to this. And actually, there's nothing wrong with them. And sometimes when their coaches are pushing them more and more, they have reached their limitation and they can't go further. So sometimes we say that probably not them, it's their coaches which need to be consulted. Rarely we do see obvious pulmonary abnormalities which can lead to limitation. We have a huge PACTUS program here. Although in PACTUS it's mainly a cardiac limitation by restriction, but you can also see restrictive physiology in PACTUS which can lead to limitation due to lungs. And rarely if patient has interstitial lung disease or significant malacia, that can lead to exercise intolerance and could be the cause of EID. Cardiac cause, so we have our cardiac colleague, Dr. Sabati. He sees a lot of these patients. As a pulmonologist, we do not routinely see patients who have underlying cardiac issues, but we are always look out for these kind of patients because although these causes are rare, but it could be fatal. And hypertrophic cardiomyopathy is one of that diagnosis. If someone is passing out during activity, that's a red flag for us, and that patient need to be evaluated for cardiac reasons. We always ask for any personal or family history of heart disease. Obviously, if there is a certain cardiac death in less than 50 in the family, that raises a red flag, or if there is any finding on the examination which is suggestive of heart disease. In last couple of slides, I will highlight that there are many other causes other than EIB which can lead to exercise-induced dyspnea. This is a study which was done in 2005. They looked at 142 patients, and what they found who had cardiopulmonary exercise testing, and what they found only 11 had EIB, which is less than 10%. Majority had physiological limitations, some had restrictive abnormalities, and few had VCD. We also, where I was before, I published my experience for cardiopulmonary exercise testing, and that was published this year in January in Annals of Allergy, Asthma, and Immunology. And what we looked at is 5 years worth of cardiopulmonary exercise testing and find out what were the common causes in our patients. And this is a cartwheel for our diagnosis, and what we found is that only 10% had EIB, and there are a lot of other causes which are there. Pulmonary limitation is in very few, physiological limitation and vocal cord dysfunction made a huge part. One thing I want to highlight here is that sometimes it is multifactorial. A patient with EIB can have a deconditioning too. Obesity itself does not mean that they are deconditioning, but you can have deconditioning associated with obesity as well. So important thing to remember is that there are many other causes of EID other than exercise-induced bronchospasm, or other important thing to remember that it could be multifactorial. This was one of the article I wrote for AAP News a few years back, just highlighting the same thing which I'm telling here, that exercise-induced dyspnea can have many causes. So as I promised that I'm going to go over the algorithm I use in my exercise clinic. So let's say you see a patient with exercise-induced dyspnea. If patient has diagnosis of asthma, then I think trial of short-acting bronchodilator before exercise is totally appropriate. If they improve, just follow up. And obviously, if they're needing that albuterol frequently, then maybe consider controller therapy. If they do not improve, then look for other causes. Remember, they can have their exercise intolerance could be multifactorial, like a patient with obesity with asthma, or a patient who had a vocal cord dysfunction with asthma. And then it may not be inappropriate first to do just a simple exercise challenge testing on those patients, because common reason could be that they are not adequately treated. And the likelihood of that exercise challenge testing coming positive is high. So in those selected patients who have asthma and have EIB and are not able to be controlled despite adequate treatment, the first thing, you can order a simple exercise challenge testing, but if that doesn't give you an answer, then consider CPET. Patients who have atypical symptoms. So I had one patient who would have exercise intolerance when she would be at certain corner or certain place, which obviously is not typical of any of the exercise intolerance. Doing a CPET directly for these patients makes more sense. Similarly, patients who do not have asthma and comes with exercise intolerance, in these patients, I think it may not be unreasonable if you think sometimes what happens is these patients had issues when they were young for asthma, and then for many years they did not have anything, and now they're 12, 13, and now they're having issues. In these patients, and they've totally forgotten about what happened when they were young, they may be on inhalers or nebulizers, and they'd never considered themselves that they had asthma. These kind of patients, or even if they did not have any obvious history, if you want to try albuterol before activity, that is not unreasonable. However, if they do not improve significantly, then always consider CPET, because you want to look for other causes of exercise-induced dyspnea. Just to highlight what is the role of CPET in EID, is that any patients who have atypical symptoms, patients without asthma, if after a short trial of albuterol it's not improving, and patients with asthma who do not show improvement even if they are on adequate treatment. These are the patients you want to think about considering CPET. So two group of patients, patients with asthma, if not improving despite adequate treatment, because remember, their cause could be multifactorial, or patients without asthma, I will have a low threshold of doing a CPET in these patients. You can try albuterol for a month or two, but if they do not improve significantly, then they should get a CPET. If parents are interested to know what is the cause of their exercise intolerance. So in conclusion, exercise-induced bronchoconstriction is a common cause of EID, especially in patients with asthma. It is well characterized and there are effective ways to treat it. Always consider other causes of EID when either the history is not typical or the treatment is not effective, especially in patients without asthma, patients who have atypical symptoms, or in patients with asthma who do not show improvement or significant improvement despite adequate treatment. So these are my references. I just want to highlight our team here, Dr. Sabati, who is a co-director of the Human Performance Lab. He's a cardiologist, so he sees a lot of patients with congenital heart disease, adult, children, or patients with chest pain. Then Colin Connor, who is our NP, who also helps us in the exercise lab, and Erika Huffman, who is an exercise physiologist. She is a new addition last year, and she actually performs all the exercise studies for us. And that's my contact. I have also given the phone number and the fax for our administrative assistant for any referrals. I also run an exercise clinic, which if you are not sure that you would like me to evaluate before we want to order a test, or you're not sure which test to order, you can feel free to email and I can help you that way. Or if you want me to see that patient in exercise clinic, I'll be happy to do so. Or if you just want to send a referral, you can talk to her or fax the referral. So with that, I'm going to finish the talk and open the floor for the questions.
Wonderful. Thank you so much, Dr. Bhatia, for the excellent presentation. Got a couple questions. And I've been interacting with Dr. Sabati. He was actually highly offended by the heart comment, so he wants to be able to defend himself. So, Dr. Sabati, are you able to unmute yourself?
Yes, can everyone hear me?
Yeah, go for it.
Sure.
Thank you very much, Rajeev. That was a very, very interesting talk. My first question is, since you went through so nicely VCD and exercise-induced hyperventilation for us, can you give everyone an idea of the treatments? How successful are they? What's the time course, the length of the treatment? What's the prognosis? Is this a lifelong disease? What should people expect if one of their patients gets one of these diagnoses in terms of short and long-term changes in outcomes?
That's an excellent question.
I know.
And I promise I did not want him to ask this question. Okay. So the VCD is what I have found. It depends on a patient too. And sometimes, most of the times, we just send them to speech therapists and they can handle it. If I see a patient who have a lot of other psychological issues going on, let's say I had a patient who had OCD and hyperventilation, or OCD with VCD, in those patients, I have sometimes sent to a psychologist, and that has really helped. And it depends on a patient. Some patients, maybe 1 or 2 sessions are enough. Some patients, it takes longer. However, the prognosis of my patients has been great. Actually, most of these patients, as I was saying, are really smart. And what they started to do is that they started to identify these symptoms sooner and sooner, and they start those breathing techniques. So what I tell them to train themselves in these breathing techniques at home when there is no stress, so that it becomes their second nature. And what happens on the field, as they get more and more comfortable with these breathing techniques, they start to identify these symptoms much sooner, and they start doing this breathing technique sooner and sooner, and where the point comes, it almost becomes a second nature, and they do not even remember that they were doing it. So to answer your question is that it depends on the patient how many sessions, but overall prognosis is good. Most of the patients do okay.
Great, thank you. And then another question that I thought would be important to address for all the general pediatricians and primary care providers in the room. If you're seeing a patient either in clinic or in the emergency room setting that's giving you some symptoms of exercise-induced dyspnea, obviously without exertional syncope, but some exertional dyspnea, do you have any precautions or restrictions that you would recommend they undertake for safety of exercise? Just how can they counsel the family once they see them before they get to see you in exercise clinic and have their testing done?
That's another good question. So if I'm not worried that it is cardiac, I usually do not tell patients to have any kind of restrictions. Obviously, I just tell them to do it as tolerated. Fortunately, most of the patients we see, I can say more than 90%, it's rarely we find something very significant. We have had 1 or 2 patients which came to our door, had significant arrhythmias. So if you have ruled out any cardiac cause, and many times they have already, by the time they come to us or by the time they have already seen a cardiologist. If the cardiac cause is ruled out, none of these causes are life-threatening. Then I usually don't put any restriction. I usually tell them to do exercise as tolerated, and then see a specialist if that's already planned.
Thank you. And one final question for you. Since you did mention the importance of the heart there, and that patients are typically limited by their heart or their peripheral muscles. But as you know, that this is dynamic. The heart's a muscle. You can train the muscle to get better. This is what happens with elite athletes: is their heart muscles and their peripheral muscles become trained, but you really can't change or increase your lung capacity. So, given that, how jealous are you of the heart on a 1 to 10 scale? Give us a number between 8 and 10.
I missed the last one.
How jealous are you?
How jealous of you are the heart? Give us a number between 1 to 10.
I would say that was like a sneak attack in a form of question. But I definitely totally admire that cardiology, that heart can improve their cardiac output, which lungs can, but not into that extent. So I take that
So the real question there, Rajeev, what would you say about recommendations for exercise with these patients who have either asthma, exercise-induced bronchospasm, VCD, EIH, deconditioning? What do you generally advise them regarding? So you gave the answer for what the pediatrician should look for. Now, after they're diagnosed, what do you advise them all to do from an exercise standpoint for their lungs and their overall health?
So that's a great question. Also another great question. So if patient has EIB, I always give an example of Olympians. Actually, exercise-induced bronchoconstriction is the most common diagnosis in Olympians. So having said that, I tell them this should not limit you. As long as you are taking good care of your asthma and EIB, it should not limit you. So I do not stop them. I tell them they can do anything. As I said, that even the Olympians many of them have EIB. As far as exercise prescription, if you were asking that, what we usually, as you know, there is a standard formula for exercise prescription. We look at what is their max heart rate or what is their max VO2, and then look at 50 to 70% of that. And there is actually many sites where you can see what is the VO2 at, like when you're biking, what is your VO2 or what is your kind of METs, and that way you can prescribe them so that they stay in their 50 to 70%. That I'm talking about a patient with deconditioning. So in summary, I mean, I don't want to go in detail, but you can, as you know, that you can give them a particular exercise prescription based on certain formula, and there are many sites to tell you what kind of activity, what kind of METs you burn at particular activity, and based on patient's interest. So I had a patient who liked to bike, so I told them what they can do. One patient who was significantly obese, I even, based on what their VO2 was, even brisk walking was at 50 to 70% of their max VO2. So it depends on what kind of patient we have, but as you know that we can give them a particular exercise prescription.
Thank you very much, Rajeev. Really appreciate it.
Sure. Thank you.
I've got another question here from Dr. Damon Dixon, another of your cardiology colleagues that you've provoked here. And I think this is very similar to what was just asked. He says, should we consider exercise testing in obese children with mild risk factors, for example, borderline hypertension, dyslipidemia, insulin resistance, to have a baseline exercise test and provide exercise prescription for primary prevention strategies?
I think that's a great idea. Unless we have an objective measure, how do you know? And we know that exercise itself can improve many of these parameters. So actually, I had initiated one of the projects, but it did not end up finishing it. But we had collaborated or asked to collaborate one of the obese program where I was before and see if we can do these studies and kind of see the progress as they were doing some kind of exercise program. But I think that's a great, if we can include that, that would be great.
And a question from Dr. Hartley. Sorry, give me just a second. All right. Is there any significance if the patient has a max heart rate that is above what the equation predicts for age? For example, are physically fit patients able to achieve a higher heart rate than unfit patients?
So actually, it is vice versa. As you are getting fitter and fitter, which Dr. Sabati pointed out, that as you become more and more fit, your stroke volume tends to get better, and your heart rate then does not need to go as high in comparison to other patients to provide the same cardiac output. So actually, we see a lower heart rate in a fitter patients. I'm not talking about very low, but relatively lower heart rate. Sometimes we do see higher heart rate. Higher heart rate, you would see more for the same VO2. I took off that slide, but that slide kind of clearly explains that if more deconditioned you are, then you have a much higher heart rate at the same VO2. So if your heart rate is spiking up very quickly, unless you have any heart condition, that is kind of an indirect sign of deconditioning. What that means is that your stroke volume is not able to keep up and your heart rate start to rise much quicker and higher. So to answer your question, in conditioned individuals, we rather see a lower heart rate for the same VO2 in comparison to the unfit individual.
And, thank you. We have a question from Dr. Rakowitz. How important do you think the type of exercise done during the exercise testing is? For instance, it can be difficult to evaluate swimmers for EIB when tested on a treadmill in the lab because it's a different environment than swimming in a chlorinated pool. Do you think you can exclude EIB with a normal exercise challenge in a swimmer?
Very, very good and very interesting question. So there is always a caveat. So first I will talk about different types of exercise testing, and I did not talk about that. So you can do exercise challenge or cardiopulmonary exercise testing on a treadmill or on a bike. So many of our cardiology colleagues like it. Many places like bike because it's easy to, you can get an EKG very well. It is relatively for a younger kids, they can bike easily. The problem sometimes is that sometimes you don't reach to your VO2 max because their legs can get tired sooner before their heart and lung reach to their peak. So that is a different exercise. So you can do bike or treadmill. For your second question, it is always a caveat. It's very difficult because we always, so to answer that question, I had a patient who had symptoms in an ice rink. He was a hockey player, and he had symptoms which were very obvious that it was EIB. Parents were not convinced. We did the study, and unfortunately, it did not show bronchospasm. But I was very convinced because he was fine otherwise. As soon as he would enter an ice rink, as you know, the cold, dry air can do that, and he would start wheezing, coughing, and albuterol was truly helping. And for some reason, these parents were very adamant against the diagnosis of asthma. So we said, okay, let's do the cardiopulmonary exercise testing. We made sure that he ran enough so that if he had EIB, that would be induced. Unfortunately, it did not show. And my explanation for that is that this exercise testing, as you mentioned, cannot simulate exact conditions what is there. So in the end, we end up treating that patient, and that patient was fine, and that is a bigger kind of testament that this patient had EIB and asthma. So to answer your question, yes, you have a different modes of exercise. Those are bike and treadmill, but you cannot simulate exact conditions. And that caveat we always have. And if I have a strong suspicion, I still do not take them off inhalers, even if it does not show EIB.
Thanks everybody for the questions. Dr. Bhatia, thank you so much for an excellent presentation. Very interesting, and I hope everybody has a great day.
Okay, thank you.